morning everyone. Today, continuing our series of continuous cardiac education program initiated by our institute, UNMICRC Institute, I'll be speaking about ischemic mitral regurgitation. Hello everyone, I am Dr. Shobhit Mathur, AP Cvts at UNMICRC Institute of Cardiology and Research Center. So starting with the presentation, before starting my presentation, I would like to state that I am not owning any of the materials that I will be presenting in the coming presentation. The data and all have been taken from the standard textbooks of cardiothoracic surgery, that is Kirkland and Sebastian Spencer, and some images have been taken from the internet. So starting with the presentation, firstly we'll start with the definition. So mitral MR is basically mitral regurgitation. We all know what is mitral regurgitation. Regurgitation caused by ischemic heart disease is ischemic MR. It is not to be confused with MR from other causes that may coexist with ischemic heart disease. The other common causes of MR in India are rheumatic MR, mitral valve prolapse, myxomatous degeneration. So they might coexist with ischemic heart disease, so they are not to be confused as ischemic MR, and they are not to be considered as ischemic MR while planning the treatment of the patient. Specifically, ischemic heart disease has to be caused. So let's again make a definition. So the definition now stands as a triad. The etiology has to be ISD, or the ischemic heart disease, coronary artery disease, and evidence of prior myocardial infarction with regional or global dysfunction or dilatation of the LV. So what is causing the MR, the ischemic MR, is basically CAD, causing myocardial infarction. It can be recent or it can be an old infarction with regional or global dysfunction of the LV wall and dilatation of the LV wall. The primary lesion, as detected in the very basic investigation 2D echocardiogram, has to be the tethering of leaflets. Tethering means shortening, or basically the leaflet, we'll see that how the commissures, they get mobilized, and the leaflets, they are actually acting to shorten the wall. So that phenomena is known as tethering of leaflet. So this word tethering is very specific for ischemic MR. Primary valve dysfunction is basically mitral regurgitation, restriction of leaflet motion, which occurs mainly in systole, Carpenter's type 3B dysfunction. So let's go through the definition once again. The etiology has to be ischemic heart disease. Primary lesion has to be tethering of the leaflets or shortening of the leaflets or traction on the leaflets. And the valve dysfunction causing mitral regurgitation due to restriction of leaflet motion. The tethering will cause restriction of leaflet motion mainly in systole, Carpenter's type 3B dysfunction. So let's quickly go through the Carpenter's classification, type 1, type 2 and type 3. I'll be covering this classification in very briefly. The mechanism in type 1 is basically annular dilatation. Mechanism in type 2 is basically leaflet prolapse. And mechanism in type 3B is leaflet restriction in systole. This is the most common cause of ischemic MR. Annular dilatation is common, and prolapse is less common in acute setting these days due to early PCI and interventions that our cardiologists they do. So type 1, type 2, type 1, you can see that annular dilatation is there. The posterior annular dilatation is more than the anterior annular dilatation. Leaflet prolapse is due to acute papillary muscle rupture, commonly the posterior medial muscle rupture due to single blood supply. If we go through the anatomy, then we all have studied that there are two commissures of the mitral valve, anterolateral and posteromedial. Anterolateral commissure is supplied by branches from the LAD and from the circumflex. And posteromedial commissure has got single blood supply, that is mainly from the posterior descending artery. It arises most commonly from the RCA and in some cases from circumflex. So leaflet prolapse causing MR is type 2, and type 3 is basically leaflet motion restriction due to tethering. Secondly, to lateral displacement of the papillary muscles from ventricular remodeling. This slide, we can see that if you look at the papillary muscles on the right hand side diagram, we see that the posterior medial commissure muscles are due to wall dysfunction and dilatation of the LV wall. They are moving posteriorly and towards the apex. So the movement of the commissure will pull the chordae, and that will pull the leaflet down. So that will cause tethering of the leaflet or restriction of leaflet motion, mainly occurring in systole, and that will cause the MR. Now on the left hand side, if we see that what happens to the annulus, this distortion, and the posterior medial part of the posterior leaflet is moving posterior apically due to tethering of the chordae, and that is causing tethering of the leaflets. And here we can see that how the MR is caused. This is again a schematic that what happens after the infarct. The posterior medial muscle commissure gets displaced, and that will pull the chordae, and that will cause the leaflet tethering, and that will initiate MR. So, how this entity has evolved and how our understanding has evolved through history, we'll see in this slide. That mitral regurgitation from rupture of a papillary muscle is a rare and a frequently catastrophic complication of acute MI. Obviously, any rupture of muscle is always a catastrophic complication. The case was first identified at autopsy at Johns Hopkins Hospital in 1935. First antemortem diagnosis was made in 1948. MR without papillary muscle rupture due to tethering occurring as an acute or chronic complication of IHD with or without MI was described in 1963 by Birch and colleagues. In fact, Birch and colleagues are the people who actually gave this term, that the ischemic MR is due to the papillary muscle dysfunction. First surgical correction of papillary muscle rupture was carried out by Austin and colleagues at Massachusetts General Hospital in 1965. In fact, surgeons at Massachusetts General Hospital are among the first to replace mitral valve for ischemic MR. Now, how the acute MR complicates MI? Acute MR mainly happens due to rupture of papillary muscles. 50% of acute MRs are due to actual rupture of the papillary muscle. In 1/3 cases, there is complete disruption of papillary muscle resulting in flail leaflets. Both AML and PML can be flailed, causing the MR. And in 2/3 cases, the rupture is partial of only one or more heads of the papillary muscles. So 50% of the acute MR are due to rupture of papillary muscles. Out of these 50%, 1/3 are due to complete disruption of papillary muscle, and 2/3 is due to only the disruption at the heads of the papillary muscle. Posteromedial papillary muscle rupture is the commonest. Why? Because of single blood supply. Anterolateral muscle rupture occurs in about 25% of cases, and the difference is due to the collateral circulation by the coronaries. So the inferior-posterior LV infarction is a common cause of posterior medial papillary muscle rupture. There can be associated rupture of interventricular septum as well as free wall of LV. So in rare cases, in some cases, the ischemic MR, the acute ischemic MR can coexist with VSR as well as a free wall rupture. Papillary muscle necrosis without rupture. This causes 50% of the acute MRs. So understanding the acute MR, 50% was due to papillary muscle rupture and 50% is due to only necrosis, not rupture. This is basically papillary muscle dysfunction. The distribution of the necrotic changes and the extent of MI are similar to those that I have already described for papillary muscle rupture. Other causes of acute MR. Moderate to severe MR happens in 3 to 19% cases of acute MI, and this is a very important predictor of mortality in acute MI. The causes can be changes in configuration of the LV, that is remodeling, global or segmental LV dysfunction, changes in the function of mitral valve resulting from the leaflet prolapse, abnormal closure, and annular dilatation. The LV systolic dysfunction, increased LV chamber sphericity, regional asynergy of the infero-posterior lateral wall overlying the posterior papillary muscle are the most important determinants of developing MR. Let me repeat this thing again. That basically the systolic dysfunction, increased sphericity of the chamber, LV, regional asynergy of the infero-posterior lateral wall that overlies the posterior papillary muscle is an important determinant of developing MR. Changes in configuration and contractile function of LV after an acute infarction prevent adequate coaptation of leaflets and result in MR. Chronic MR. Chronic MR can be due to ISD, or as I said earlier, that due to RSD or myxomatous degeneration, it can coexist with ISD. So this distinction is always difficult. Why? Because papillary muscle scarring or fibrosis is not always a result of earlier necrosis or adjacent MI. The regurgitation may be localized to the region of posteromedial or anterolateral commissures or both. The underlying papillary muscle ischemic dysfunction, papillary muscle scarring, shortening or even lengthening of the chordae, previous rupture of a portion of papillary muscle, asynergy of the adjacent LV wall, and LV remodeling. These all are the mechanisms that are leading to the development of chronic mitral regurgitation. So the jet in most of the cases is not a central jet. In classical cases, central jet can happen if the leaflet motion is getting restricted with increased leaflet tethering, that is an associated annular dilatation. So coming to clinical features. Acute MR. Acute MR is due to papillary muscle rupture, so it will always present acutely. Few hours to 14 days after an MI. This is basically the timeline of presentation of acute MR. The presentation is always with pulmonary edema, hypotension or both, typically 2 to 7 days after MI. Patient mostly present in profile. If the rupture is total, then the cardiogenic shock sets in, and the patient usually present with profound shock. So pulmonary edema, hypotension, and profound cardiogenic shock in cases of total rupture, typically 2 to 7 days after the onset of MI, is the clinical presentation of acute MR. If you put a stethoscope on the chest wall, then you can hear an apical systolic murmur, apical gallop rhythm S3. The LA size on the X-ray will be small or normal. The PA pressures will be increased and there will be prominent V waves. Obviously an echo has to be done. So echo will be able to differentiate between papillary muscle rupture and LV dysfunction. On echo we can have extensive wall motion abnormalities. If it's a case of muscle rupture, then the leaflets will become flail and they will prolapse into LA during systole. The ruptured portion of the muscles can be directly visualized as a separate mass attached to the chordae. Some advanced investigations can be done. For example, left ventriculography if we are suspecting associated VSR and associated aneurysm of the LV wall. This investigation is not required for the assessment of mitral regurgitation. Mitral regurgitation is very well assessed on echo, that will be able to show muscle rupture and prolapsing of the leaflets, and the ruptured portion of the muscle, as I said, is directly visualized as a separate mass attached to the chordae. Left ventriculography only for the assessment of VSR and LV aneurysm. And obviously a coronary angiography has to be done for surgical planning. So looking at the clinical features of chronic MR, chronic mitral regurgitation will present as a gradually increasing mitral regurgitation, slow and insidious symptomatology. The murmur might date from the attack of acute MI, so that points an indication towards the ischemic etiology. On evaluation, we will see that cardiac enlargement is there, and specifically LA enlargement is there. In acute cases, LA was small or normal in size. There can be hypokinesia, akinesia, and wall motion abnormalities of the LV wall, and LV aneurysm may coexist with a presenting chronic MR. Two advanced investigations we can do is positron emission tomography, PET, or a dobutamine echocardiography. The importance of these investigations is basically a chronically ischemic hibernating myocardium is visible on PET. The importance is that it will respond very well to revascularization. So for future surgical planning, if we see a hypernating myocardium on PET, that means the results will be good if we do a proper revascularization. Gadolinium contrast enhanced MRI will be able to show myocardial scarring, specifically in the region of posterior papillary muscle, which is extensively scarred. And as we know that extensively scarred muscle is non-viable. So annuloplasty in these cases will be insufficient, and it will be better if we go for a mitral valve replacement. Natural history of the disease. Acute MR is less prevalent now. Why? Because of advanced thrombolysis and PCI that is available. Life-threatening acute MR is usually life-threatening. 75% of the medically managed people, the medically managed disease will die within 24 hours or just after 24 hours. I am specifically speaking about cases of total rupture. So total rupture, if medically managed, 75% will die within 24 hours or just after 24 hours. Survival after partial rupture is better. 70% will survive the first 24 hours and 50% will survive 1 month. And after 14 days, it is considered to be a chronic MR. If the papillary muscles are intact, then the natural history is less well defined. This history of acute MR is basically for papillary muscle rupture. And as we all know that acute MR is an important predictor of mortality in cases of IHD. Chronic MR is basically a gradually progressing mild to moderate MR. It becomes persistent and gradually it becomes severe MR. So a severe MR has got worse prognosis for patients with poor LV function. The increasing severity of MR has got adverse effects on survival. Now coming to surgery and basically to the various surgical principles that have to be practiced while surgically treating the ischemic mitral regurgitations. Acute MR patients, they are critically ill. So prompt placement of intra-aortic balloon counterpulsation pump has to be considered. CPB can be initiated in operating room, and if on an urgent basis, then a percutaneous CPB can be initiated. Patient is draped for CABG, then a sternotomy, graft preparation are accomplished expeditiously. Two venous cannulas have to be placed. The percutaneous cannulation is now converted to a central cannulation or a routine cannulation. But the percutaneous lines are left in place. They are removed at the end. So what we have learned here in the treatment of acute MR, that the patient will be very sick. Prompt placement of IABP and prompt initiation of CPB has to be there. If required, initiate percutaneous CPB through common femoral artery and common femoral vein. Then do a sternotomy, then do a graft preparation, and then we must try to establish routine CPB through central venous cannulation. Peripheral cannulation lines are clamped, but they are left in situ, left in place, and they are removed at the end of the surgery. At some centers, they are using warm induction cardioplegia and controlled aortic root reperfusion. Basically, if we are expecting a long surgery, then this thing is helpful in preventing the reperfusion injury once the aortic clamp is off. However, at our center, we are following the normal cardioplegia protocols. The coronary sinus or the retrograde plegia is very helpful for initiation of cardioplegia. One of the very important surgical principles is that the distal anastomosis has to be done first, because if we are implanting any prosthesis, say a ring or a complete valve replacement has to be done, then after replacement or after ring placement, lifting the heart for distal anastomosis, especially of the OMs and the posterior descending arteries, can cause disruption of the LV wall. So that has to be avoided. So always do distal anastomosis first. Proximal anastomosis can be done after distal anastomosis or after addressing the mitral valve, depends upon the surgeon's preference. If proximal anastomosis has to be done after closing the LA, then it is to be done with the aorta still occluded or after declamping and patient, or after removing the aortic cross clamp and applying a partial clamp that we usually do for the routine proximal anastomosis. The approach for mitral valve has to be LA. RA in some cases, if LA enlargement is if it's a huge LA or LA is very small, then in that cases we can take other approaches for mitral valve, especially the RA approach. For acute total papillary muscle rupture, if the rupture is total, complete, in acute setting, then a mechanical prosthesis or a bioprosthesis has to be used. And the choice of surgery in these cases is mitral valve replacement, not repair. The annular tissue is friable in acute setting, it is not thickened. So bites have to be taken very carefully. And even after taking the bites, excessive traction on the suture as well as while taking the sutures and while lowering the valve has to be avoided. Otherwise, we may encounter a cut-through suture. Pledgeted mattress or non-pledgeted simple interpret sutures are preferred depending upon the surgeon's preference. The other option is repair of the mitral valve by a ring annuloplasty and sometimes suture annuloplasty. The specific indications are for doing an annuloplasty is that the papillary muscles are intact, they are not ruptured. Caudal mechanism is intact. If a rupture has been there, then only one head of the commissural muscle is ruptured and annular dilatation is there. Ring or band, when it is used, it has to be one size less. That is called restrictive annuloplasty. What it is, we'll see in the coming slides. A transesophageal probe is used for assessing the competence of valve. And the competence of the valve has to be assessed specifically when the LA pressures are minimum 15 mmHg and systolic blood pressure is more than 120. If the valve is not competent, then immediately CPV is re-established and the valve is either repaired again or better replaced with a prosthesis, mechanical or bioprosthesis. IBP, if not placed previously, has to be kept standby. So, I'll once again recapitulate the surgical principles for treatment of acute MR. Patients are critically ill, promptly place an IBP, do not hesitate. Secondly, initiate CPB very fast. If required, initiate percutaneous CPB, then do a sternotomy and then convert it into a routine cannulation. Cardioplegia, try to use the coronary sinus route or the retrograde cardioplegia, and if the center is using it routinely, then warm induction of cardioplegia can be used. While doing the CABG part of the surgery, always do the distal anastomosis first. Okay? And before doing any intervention on the valve, we have to do our distals. Proximal anastomosis can be done as routine. The approach for mitral valve has to be LA, most common approach, and RA if required. In cases of acute total papillary muscle rupture, do not go for suture repairs, go for mechanical prosthesis or bioprosthesis. Annulus tissue in acute settings is not thickened and it is friable, so careful bites have to be taken, otherwise we can have a rupture. If a ring annuloplasty has to be done, then there are specific indications. The papillary muscles are not ruptured, caudal mechanisms are intact. If a rupture is there, then there is rupture of only one head and there is annular dilatation. If a ring or band is used, then it has to be one size less, causing restriction of the annulus. T is used to assess the competence of mitral valve and or the competence of our ring repair. The competence has to be assessed at LA pressure minimum 15 and systolic pressure minimum 120. If the valve is not competent, immediately we have to re-establish the CPB and either repair it again or better implant a prosthetic valve. IBP or ventricular assistance devices have to be kept standby. Sometimes even we have the specific indications, but we might encounter some difficulties in intraoperative decision making. because of the variability of the magnitude of the regurgitation and uncertainty about the precise morphologic basis of regurgitation and frequency with which the mitral valve regurgitation is associated with poor LV function. So the treatment decision of repair or a replacement has to be individualized. What we have to see is basically that the annulus is normal or is slightly dilated. Leaflets are usually normal. Chordae tendineae are not shortened or elongated. Papillary muscles may be pale, scarred, or normal. T has to be used for evaluation. What I was speaking about is basically the visual examination of the morphology of the valve. So if the valve apparatus looks more or less normal, then we must go for a annuloplasty. If rupture is there, it's always better to implant a new valve. If the regurgitation is severe, both pre-op and intra-op, and the regurgitation component of the disease is dominating the clinical picture, then the first choice is mitral valve repair, the second mitral valve replacement, and the second choice is repair. If the regurgitation is variable, both preoperatively and intraoperatively, and severity lessens after the CABG portion of the surgery, then mitral valve can be left alone. Intermediate situations, decisions have to be individualized. For repair, always do T after discontinuing CPP. If it is unsatisfactory, repair it again or replace. While doing the replacement, we have to be a bit cautious that we have to preserve the chordae tendineae to both AML, PML, or both. Regarding the post-op management, we all know that the patient has to be wheeled into the ICU and routine post-op care has to be given. Be aware about the low cardiac output states, and IBP, I've already mentioned, is very helpful, and catecholamine support. So looking at the results of the surgery, firstly we will talk about the early hospital deaths post-op. So in cases of acute MR that are complicating MI, the early post-op mortality is high. It is 18 to 22%. Without rupture of a papillary muscle, the mortality is particularly high for the cases that are presenting with cardiogenic shock. Early mortality depends upon the extent of MI, and it is actually a function of the extent of MI, and hence early reperfusion of the ischemic myocardium is beneficial in such cases. In cases of chronic MR from IHD, patients who are not in cardiogenic shock, the mortality is 3 to 11%. Risk factors for mortality in chronic MR cases are low ejection fraction, extensive MI, advanced age, renal disease, lower hematocrit, left ventricular and diastolic diameter more than 65 mm. This dimension has to be remembered. We will keep talking about this dimension in this presentation. And longer CPB time, need for inotropic support. Repair and replacement both have got comparable mortality. If concomitant procedures are done with the surgery for chronic MR, for example, LV aneurysm, the resection of LV aneurysm, LV aneurysectomy, then the hospital mortality gets increased. Operation done acutely due to rupture of papillary muscle, the late results are favorable. Here we are talking about the time-related survival, not the early hospital deaths. So early surgery in cases of acute rupture of papillary muscles, the long-term results are favorable. The 5-year survival is 65% to 68%. Poor survival has been noticed in cases of LV dysfunction. Overall, the cases that are treated surgically, they do better than the cases that are managed medically. If resection of LV aneurysm has been done, then this is a risk factor for premature death. Gilinovs and colleague, they have done a study, and their study says that patients who are not at high risk, for example, young patients, lower NYHA classification patients, fewer wall motion abnormalities, and no renal dysfunction, repair had higher survival at 5 years. There was no survival benefit for repair among the high risk patients. So the high risk patients, mostly we should go for mitral valve replacement. Symptomatic relief is generally good. And more relief has been observed in cases where the LV end diastolic diameter is 65 to 70 mm on echocardiography. So now I'll be summarizing the indications for surgery, and we'll be very specific with the indications. That acute MI presenting with acute mitral regurgitation. Acute MI presenting with acute mitral regurgitation, the surgery has to be done early. Operate before hemodynamic compromise sets in. Why? Because that thing reduces the in-hospital mortality. Otherwise, once the hemodynamic compromise sets in, the hospital mortality is very high. If the patient is hemodynamically stable, then we can think about delaying the operation, say for about 2 weeks to 2 months. In case of papillary muscle rupture complicating acute MI, prompt surgery has to be done except when the patient is moribund. So more or less in cases of acute MI with acute MR, surgery is the mainstay of the treatment. We can avoid surgery if the patient is, we can delay the surgery if the patient is hemodynamically stable, and we can further delay the surgery if the patient is moribund. In cases of chronic MR from ISD, the indications are usual. That the usual indications for treatment of mitral regurgitation. Moderate, more than grade 3 on intra-op T, repair oblique replacement has to be done. Severe MR with low EF, that is 10 to 20%, replacement is the choice of the surgery. If the patient is not falling into any of these indications, then and MR is severe, wall motion abnormalities are there, EF is very low, dilatation of the LV has happened, then the patient can be worked up as a transplant candidate. So now coming to annuloplasties, I would like to discuss this topic briefly because this is basically the technique that is employed for repair of mitral valve in cases of ischemic mitral regurgitation. The processes that are available are posterior annuloplasty bands. You can see the diagram B that is showing annuloplasty done on the PML, and the other type of processes are complete rings. You can see the diagram C that shows a complete ring covering both the post-PML annulus and the AML annulus. Complete rings can be flexible, semi-rigid, rigid, flat or shaped. Rigid rings have got a better symptomatic improvement. Why? Because improvement in the degree of MR is there more than the incomplete bands, and lower prevalence of recurrent MR as compared to the incomplete bands. Restrictive annuloplasty. See, this technique has been pioneered by Boiling and colleagues, basically reducing the size of the annulus. The standard sizer for selection of the ring is that conforms to the AML intertrigonal distance. In restrictive annuloplasty, whatever the sizing has been confirmed, a ring size 2 or less, 2 or more sizes smaller is selected for elimination of MR for doing the annuloplasty. Why? Because elimination of MR is there, and secondly, it causes reverse remodeling of LV. So this is the procedure of choice in cases of LV and diastolic diameter 65 mm or more. There has been a lot of debate about restrictive annuloplasty because the disadvantage is that it induces a state of functional mitral stenosis. But compared with the advantages that regarding the elimination of MR and the reverse remodeling, this technique remains the mainstay of annuloplasty in cases of ischemic MR. The alternative techniques for repair that can be employed, mitral valve repair in itself is a voluminous topic. So I'll be speaking briefly about the techniques that are usually employed in some centers for treatment of ischemic MR. So the alternative techniques are division of secondary cords, caudal cutting. This thing will obviously reduce the leaflet tethering effect by the cordees. The secondary cords to AML and PML are severed, and again an undersized posterior annuloplasty is done. It causes greater mobility of AML and less recurrent MR. PML extension can be made with pericardium. This technique has been pioneered by D. Varnies and colleagues. In this technique, we are basically enlarging the posterior half of PML P2 and P3, half of P2 and complete P3 with 1 into 3.5 to 4.5 centimeter patch of bovine pericardium. Annuloplasty ring in this technique is of normal size, it is not downsized. And one of the techniques that has been pioneered by Krons and colleagues is basically relocation of the posterior papillary muscles. What is happening in the cases of ischemic MR, the main pathophysiology says that the posterior papillary muscle gets displaced. So in this technique, we are trying to correct the displacement, and which will correct the tethering of the leaflets. So that is called relocation of the posterior papillary muscle. How it is done is basically a 3-0 polypropylene suture is passed twice through the heads of the posterior, through the fibrous portion of the tip of the posterior papillary muscle. And after passing it through the tip of the papillary muscle, the suture is passed through the adjacent annulus and is tightened until leaflet coaptation is achieved. So in this, I am presenting here a diagram. In the A part of the diagram, we are seeing the displaced papillary muscle, and after employing this proline traction suture and tightening it, that the displacement has been corrected and the papillary muscle has been relocated. So that in turn reduces tethering, and that in turn reduces MR. Again, if required, an annuloplasty ring can also be used in this technique. A papillary muscle sling technique advocated by Havas and Jodinat. What is done in this technique is basically this technique employs mobilization of the trabeculations of posterior papillary muscles through the mitral valve. A 4 mm tube of PTFE is drawn around the two papillary muscles. The intraventricular sling is secured with sutures so that there is no gap between the muscles. An annuloplasty ring is also used in this technique. So after employing all these techniques, there are still cases with recurrence. So there are certain indicators, especially on transthoracic echocardiography, and also on transesophageal echocardiography, that basically give us an idea that this case will have a recurrence or not. So from the surgical point of view, the use of flexible rings, incomplete rings, inadequate rings sizing are basically the causes of recurrence of ischemic MR. Recently, there have been some techniques that have been developed. Basically, they are still in the pipeline stage. So, edge-to-edge leaflet approximation, external or internal, infarct plication, and external restraint systems are currently under investigation. Heart transplantation is a viable alternative for patients with advanced disease. So, with this, I would like to end my presentation. Thanks a lot.